You can switch off your video to Nesisa if it's okay, and then come with clarity too.
As dawn breaks over Johannesburg, the busiest city centre in Africa hums to life as hundreds and thousands of South Africans stream into the city to chase their piece of the golden dream. Thanks to a vibrant revitalization effort over the past couple of years, the Johannesburg CBD is the vital centre of life for the many who study, work and play there. And now, Clinics' First Day Hospital is right in the heart of the CBD to help sustain and enhance that life.
So Clinics has got the longest history in the country of providing the platform for black professionals in particular to be able to deliver care in the private sector. And our oldest hospital in the group, Dr. S.K. Matseke, has been doing this since 1985, and we have got a great experience, and we have got a large network of specialists across our facilities who are highly skilled in the different disciplines of medicine. We are really in a very good position to be able to make those skills and expertise available to the communities and the people who work and live in and around the Joburg CBD.
For more than 30 years, the Clinics Group has been striving to identify opportunities and meaningful ways to pay tribute to our founding fathers, who epitomized the concept of black excellence from the start. And it is in tribute to these visionaries that this hospital is named after the astute businessman and legal expert, Dr. G.M. Bike.
Dr. Pitcher was, to me, he was very, very special. From the home front, he was my father's best friend. And there would never be any important occasion happening at home without Dr. Pitcher being there. So he's always been there. At some stage in my life, I went through difficult times. He was there for me. You know, when I went through my difficult times, we were there to listen for me. When he went through his difficult times, when he had cancer, I was there to look after him. So I've got that special relationship with him. He's a community leader to me. He's my father to me. He's everything. The founding fathers, like him, is Dr. Pitcher, but actually he was a lawyer. Okay. Dr. Ntato Matlala was a doctor, but a businessman. Dr. Mukhesi was a doctor, visionary, a businessman as well. In whatever they did, they were quite diverse. Possibly, if you look into his contribution in law, you'll find that it's major. He was the first president of Black Lawyers Association. If you went into education, you will find that he also features in education. So there was a special breed of people that worked across their disciplines.
The Dr. G.M. Bike Day Hospital at 5th services in dentistry, dermatology, optometry, ophthalmology, physiotherapy, audiology, ear, nose and throat surgery, orthopedics, gynecology, pediatrics, maxillofacial surgery, as well as general elective surgery. The 36 beds in the state-of-the-art wards and private rooms provide a safe and comfortable space for patients to recover from same-day surgeries under expert supervision. The facility also offers doctor's suites for consultations with GPs and specialists for all who work and live in the city. For the convenience of all its patients, the Dr. G.M. Bikye Day Hospital offers safe and secure parking and the use of a courtesy shuttle service for patients who need to be transported between other clinics' facilities.
You know, the business of clinics has always been to take care of the previously, historically underprivileged people. And we know that our city centers are full of such people. Our city centers are now full of people from outside our borders, from Africa, the north of where we are, and those people have not had that. They haven't had that the privilege of having the facility like the Clinics Day Hospital that is coming up now. So this is going to be a fantastic service for all of them, and we hope that the people will see the advantage of being serviced close to where they are. I think that's the whole idea of clinics, to serve people closest to where they live.
It is this ethos of excellence that provides a haven of healthcare for the denizens of Africa's busiest city. The Dr. G.M. Bikye Day Hospital at 56 Van Willig Street in the heart of Jozi is open to all every day of the week from 7 a.m. to 5 p.m. and welcomes all medical aids. And it serves as a fitting memorial to a remarkable man who dedicated his life to excellence.
Good evening, colleagues, and welcome once more to our weekly webinars brought to you by Clinics Health Group. And it's always a pleasure to be able to engage with you on a weekly basis on this platform. And as we've seen that we were showcasing the Dr. G.M. Bikye Hospital, and we're delighted that this evening we're bringing someone who actually works at that hospital, but we'll have that later on. But just to say welcome to everyone. I see we also have an attorney, Ndumbuluko Livingston Yatela. Welcome. I'm not sure if it's the first time that you join us, but we hope that you'll find this quite an engaging session, and we'd also want to hear your comments with all other colleagues who are here, the colleagues from the nursing profession, medical practitioners, allied health professionals, pharmacists, and other interested parties who are part of us weekly at AD. Yeah, please, can you just make sure that you mute that person, Kamu? Thank you very much. And please note that these webinars are CPD accredited. And we know that most of you are quite interested in the Kamu. If you can help us answer to mute whoever it is. Please, colleagues, just remember that when you log in, please make sure that you mute yourself. We're not muting you, but please do mute yourself, and also switch off your video so that we enhance the quality of audio and the colleagues will be doing presentations. This webinar is also streamed live on YouTube. So at any time after the webinar, if you want to go and watch or listen to the presentations, you are free to do so. And please ensure that when you log in and when you register, you provide your full details, your name, your surname, your registration number, whether you're with the HPCSA, the Nursing Council, or the Pharmacy Council, the Allied Health Professions Council. Or now, if you're not registered, it's okay. You're also welcome because I know that some of you work in management. And so we hope you have a wonderful time this evening listening to Sister Nesisa Ngwenya, who is a nurse by profession, trained theatre nurse at, and also has got a BK at admin and also occupational health and safety, obtained from the University of Johannesburg. And through her love for education, she further progressed her studies in achieving a master's degree in nursing education at the same university. She also holds a moderator and assessor certificate that is CETA accredited, as well as being a BLS instructor. We're using it quite a lot within the group to train some of our nurses in BLS, especially those who are in the emergency units. She also helps with the cardiopulmonary resuscitation. She's currently working at GMPH Day Hospital, as I indicated, as a theatre manager, and previously she was at our Clinics Health Academy, where we train our nurses and anyone else who wants to be trained as a nurse at our nursing academy, which is based at the Solomon Sticks Morewa Hospital. And out of her work, she enjoys writing articles. She writes articles for various journals, especially example for the DINOSA, Democratic Nursing Organization of South Africa, and the Association for Operative Practitioners in South Africa, APSA. And one of her favorite articles she wrote was the one that she wrote for DINOSA, was published in July 2022, titled Nursing Matters, Bullying in Nursing. We know how that profession also got problems, like any other profession. She has also written an article that led us to inviting her to come and give a talk this evening, titled Reducing the Risk of Medical Malpractice in the Nursing Profession. But she'll cover the whole spectrum of medical malpractice for all healthcare professionals. And she also loves pageant. She's passionate about that. She's currently with the Miss Universe South Africa group as an international pageant mentor. So excited to have you this evening, Sister Nesisa, and we look forward to an engaging session with you and quite a number of colleagues who have joined us and want to listen to you. Thank you very much and welcome.
Thank you, Dr. Bila, and thank you to everybody else that has joined in. A very good evening to everybody else. And as introduced, my name is Nesisa, and I'll be sharing on medical malpractice this evening. I'm very excited to mention that Mr. Ntumbuluka Livingstone Nyathela, an attorney at Nyathela Attorneys Incorporation, as well as mediator with the South African Medical Legal Association, co-writer as well on the article Reducing Risk of Medical Malpractice in the Nursing Profession, has also joined us in. And we'll also share a few during our discussion as well. As we all are aware that in our working environment, we are all exposed to a lot of medical malpractice. So this session will highlight some of the reasons and solutions to decrease the lawsuits in the workplace. I have only just one objective as we continue. And that is, at the end of the presentation, the listeners will be able to take patient record keeping very seriously, to protect the patient, to protect themselves, as well as protect the organization as well. So I'm just going to begin with just a little background that for the last 15 years, medical negligence claims have skyrocketed a lot in South Africa. The prevalence of these factors leads to the increased risk of medical negligence claims. So the various factors that contribute to this increasing trend include poor record keeping, poor communication with the patient, failure to exercise reasonable care by medical professionals, but we'll only discuss the first two factors only. So I'm going to share the reasons why patients or relatives would want to sue the hospital. So firstly, if the medical professionals were in fact negligent, so you would actually service, for instance, if the patient has been admitted for a procedure, patient is in theatre, and the medical professionals omit to do a surgical pause. So maybe patient came in for an amputation of the left lower limb, and because we omitted to do a surgical pause, we end up amputating the incorrect limb. So there you might find out that the professionals were in fact negligent. The other reason as well why patients or relatives would rather want to sue is when the patient received wrong medication from the pharmacy. So you'd find that maybe a patient is allergic to penicillin, and perhaps maybe then patient is given Augmentin. So patient could actually develop severe skin reactions and end up having maybe Stevens-Johnson syndrome or liver problems. So definitely they are going to sue. And also the evidence that best explains how the treatment was rendered isn't well managed, for example, on the patient's records file, and which is why the latter reason being exploited by the attorneys who actually take advantage of such system failures. So we're going to talk about the duty to keep records. So the South African Nursing Council, the HPCSA, the South African Society of Physiotherapy, etc., has rules and regulations that are set with clear practice guidelines actually for professional conduct. And as health professionals, we are required to keep accurate patient's records of all actions done to the patient, and failure to do so would obviously constitute a professional misconduct. Our professional practice requires detailed record keeping, which is very comprehensive, timely, and very accurate as well. And the courts often assess your medical records and rely on expert knowledge actually to determine the merits and payout of a claim. So due to the prevalence of the medical negligence claims, you would find out that the medical records would be put under scrutiny, basically. And it's been observed in various departments that there's usually a recurrence of incidences where professionals do not record in full detail, or rather correctly, whatever that they would have done to the patient. So the plain notes in patient records, such as your patient satisfactory, patient communicating well, patients slept well, patient fully mobile, patient awake, as an example, is not sufficient or accurate record keeping rather. And should the patient decide to later sue the hospital for malpractice, and the medical records are scrutinized, it would hardly prove believable that the litigating patient was in fact satisfactory, as indicated in the patient's file. Reasons could be because the entries on the records were illegible, the information was missing, or even inconsistencies between the entries made by the multidisciplinary team. Self-evidently, improper medical records management places the healthcare provider at risk of litigation. If litigation occurs and the records are missing or the notes are illegible and inconsistent, how can a case be properly made out to explain the standard of treatment or successfully defend the lawsuit? It will be very impossible. The healthcare practitioners need to be fully aware that when patients seek legal advice in cases of malpractice allegations, the attorneys will need to do an assessment of the patient along with the patient's file as well. Therefore, the strategies to mitigate the risk factor is to be wise and remember the famous phrase that what's not written is actually not done. So we're also going to focus on the effective compassionate communication, which is actually an essential component of quality healthcare. It is well known that the healthcare setting can be very unpredictable, complicated, and stressful, with patients' conditions changing drastically anytime. So due to the unpredictability and urgency that occurs while caring for a patient, healthcare practitioners must constantly guard against communication breakdowns. It is of utmost importance to note that there's always a correlation between communication skills of the multidisciplinary team and patient healthcare outcomes. And this is very essential to patient safety and also achieving good patient care outcomes as well. So we're going to speak about the strategies to mitigate the risk. So there are various strategies to mitigate the risk in the management of patient records and effective communication, but we're just going to focus on the two. The policy development or implementation, and also continuous professional development training. In order to improve our record management and communication skills in the medical practice, it is recommended that healthcare organizations should develop policies and standardized procedures that promote effective communication and prioritize good records management. So we're going to talk about the policy development or implementation rather. But before that, I would like to perhaps maybe remind people the policies, basically that policies are key to the success of any organization. And these are basically the set rules or guidelines for employee behavior and best practice. Policies work hand in hand with procedures, which are rather a step-by-step instruction for implementing policies. I'm sure a lot of us have seen some policies and procedures in our different departments where we are working. So if you would pair those two together, the policy and the procedures, they actually provide a well-rounded view of the workplace and help employees understand behavior and performance standards better. So now continuing with our slides, the purpose of developing or implementing a policy on record keeping will be to ensure that all aspects of care rendered to a patient by medical professionals is documented with broad assumption that what is not documented is actually not done. To define record keeping better, it is a collection of data and documentation of all activities performed on a patient by the multidisciplinary health team and kept as a record for a prescribed period and for future reference where required by the law. And that usually hits us maybe in like 10 years time or 20 years time, you could actually be requested to provide all of those things. Organizational policies would make it mandatory for all the stakeholders to commit to improving their outcomes on the key areas of records, management, and effective communication. They create a certain consistency to the application of rules and regulations in the workplace, also ensuring fairness and compliance as well. Effective communication is a function of compassionate patient care, while the management of the medical records preserves the evidence of the standard of patient care. The benefits thereof that we would have on the policy implementation would be to provide instruction on how to do the task, to create confidence and reduce bias in decision-making, because surely speaking, if you've seen the policy, read through it and use the procedure step by step as a guideline, you'll be able to actually perform whatever duty you have to. So it actually breeds confidence in whatever that you'll be doing. And it also protects staff from acting in a manner that might endanger their employment, and also protecting staff from endangering the safety of themselves and as well as others as well. And then we're going to discuss the continuous professional development training. So this is another useful tool to support and develop healthcare professionals. It strengthens the awareness of the professionals to the patient, the profession, the working environment, and as well would promote health, protect the public interest, and deliver quality nursing care to the community. Now, the Clinics Health Group has provided a WCEA portal where all professionals within the Clinics Health Group are actually able to log in and attend any CPD programs that are there. So it makes it very easy for the professionals within the Clinics Health Group to actually take part in this continuous professional development, which is actually a good thing. So the benefits to the above mentioned is to actually help keep the skills and knowledge of professionals up to date, prepare them for greater responsibilities, boost their confidence, help them become more creative in tackling new challenges, enable them to make better decisions, as well as helping them to actually take their career further. In-service training on incident reporting is also needed, especially reporting of near-miss incidents. It is not a punitive action, but prevents actual incidents from occurring. So to these ends, there must be an adequate supply of training material on the subject of record keeping and effective communication. So to make this work, there must also be a buy-in from the professional. So what I mean by buy-in is the wanting of the professional to actually want to attend this program or to attend this in-service training that will be available for them. So for instance, the senior professional leaders must be on board to supervise the junior professionals, and the junior professionals also must make a commitment to attend to continuous professional improvement programs, and the realization of any ideal requires partnership and persistence. So in conclusion, all stakeholders must work together to mitigate the risk of malpractice claims. That partnership must be understood as one that prioritizes risk mitigation through policy development and continuous professional development training. While the analysis and recommendations in this piece are in no way exhaustive, medical professionals should always proceed with the courage that it is the little steps made consistently that mark steady progress. And finally, remembering that what is not documented is actually not done. I would like to thank all of you for attending the session. And I think right now we can open up to the questions if there's any, and also extend an invitation to everybody else so we can actually discuss on this broad matter. Thank you.
Thank you very much, Sister Nesisa, for enlightening us, and especially talk about proper and adequate record keeping. And as you've been emphasizing quite repeatedly, is that what is not written is not done. So you cannot go back and say, I actually did write it at some stage, or I did it, but I just forgot to write it. Because at the moment when you see the patient, whether it's a nurse or a medical practitioner, or even a physiotherapist or any other member of the team, multidisciplinary team, there should be documentation of what you've actually done when you were consulting a patient. So I think that is a take-home message for me that we'll have to do. And the essence and importance of continuous professional development. And this is part of what we are providing here at this platform. But also, I'm glad that you are also part of the team, or you taking the lead in training our staff in basic life support also, to prepare them for emergencies and whatever may happen during the course of that mission. You mentioned that this attorney, Nyatela, who's in our midst. I don't know if he also wants to add anything from what you've just said. Your co-authors in one of the articles, you said.
Yes, I did. Mr. Nyatela, if you have something to share or to add on, please.
And all other colleagues, in the meantime, you can just post your questions on the chat box, and some Nesisa Ngwenya will gladly respond and participate.
Good evening, everyone.
Yes, Mr. Nyatela, welcome.
I'm so grateful to... Yes, can you hear me?
Yeah, we can hear you. Go ahead.
Hello?
We can hear you. You may go ahead.
I'm so grateful to join a platform such as this, where the majority of participants are medical professionals. I want to commend you on your commitment to continuous professional development. I think now is the best time, if any, for one to learn about medical malpractice and the risks that exist in the medical legal space. I want to mention that, as far as medical negligence is concerned, we have seen a spike in medical negligence cases as compared to road accident fund cases over the last 15 years. And the understanding is that most attorneys have taken an interest in medical malpractice litigation, particularly because road accident fund litigation has become increasingly difficult. Now, that may be seen as opportunistic, but there's nothing we can do to stop the trend. The only thing that can be done, as you like to say in the medical profession, is prevention is better than cure. And so I was very interested in today's subject because we speak not only to prevention, but we also speak to how you can prove that preventive steps have been taken in the place. And like my colleague Nesisa has indicated, if it's not recorded, as far as we're concerned, as far as the law is concerned, it's not done. And nobody wants to stand on the other side of the law and to prove that what they were supposed to do, they have actually done. So I was there and, and talk to each other about what.
Okay, we lost you there. Yeah, maybe if Mr. Nesisa, in your experience, you know that you highlighted the fact that proper record keeping should be done. in your experience working, not necessarily clinics, but everywhere else, and from your readings, your literature reviews, what are the common mistakes that professionals make that lead to patients litigating?
Okay, thank you, Dr. Bila. So what I have seen over the years is when a patient gets admitted, for instance, it's the first time the patient is being seen by the medical professionals, there is something that we normally would do, like physical examination. So when I was a lecturer, we used to always teach our students that physical examination is always key. So if a medical professional omits to do a physical examination, whether it's in the trauma unit or it's actually in the ward, be it medical or surgical units, if we omit to do a proper or a thorough physical examination, we are actually opening a gap, because mostly what we have seen is we as professionals, we tend to also take every word from the patient. If the patient tells you that perhaps maybe I'm not allergic to this, or I don't have any risk factors, so we actually tend to take the word of the patient. You ask the patient, so do you have any rash anywhere else? Do you have any skin conditions? They would say, no, I don't. But then should you have maybe done a thorough physical examination where you'd actually screen the patient, and it's just the two of you, and you do a thorough physical examination, you'd be so surprised that you would find a whole lot of things that could actually assist, because I would assume that in all the health organization, there is a form that we normally would use with the picture of a patient that would actually show you the spots that you need to identify. Should you perhaps maybe see a bruise, or should you see a cut, or things like that. So when you omit, when you see a slight bruise, so here's the thing, the normal. So it looks so small, it looks so slight, so I kind of overlook it. And I'm like, oh, no, that's nothing. So that, in quotes, nothing could actually turn into perhaps maybe develop into an ulcer if it was a small slight bruise, because your patient maybe is sitting or pressing, causing pressure on that actual small bruise. And over time, that bruise may result into an ulcer. And should anything, because with the relatives when they come in, so when they come in, they monitor their loved ones or the family members that are admitted. And it starts there, oh, but my mom didn't come with this. So what is this? So it all starts there. Then now you're thinking, but didn't anyone see this? Did anyone write it? Then you realize that no, actually we omitted because we kind of thought it's not important, it's too small. So that's one of the things that I've also seen where we omit to do thorough physical examination, because maybe you're taking every word from the patient and you believe the patient, but in essence, we need to actually follow the rules and do a thorough physical examination on the patient.
Thank you. So well, in the essence that you need to tend the patient. No, don't just assume that you've just examined the chest and so on, but they are the whole body has been examined. And
Yes.
now that you're a nurse practitioner, and nurses work together with doctors, and nurses are primarily there most of the time with the patient. And what are the common areas where, if there's miscommunication between the doctor and the nurse, that may lead to concerns raised by patients, and how can we assist better communication between doctor and nurse in the clinical setting? I don't know if my question is clear.
I think it is clear. Thank you for that question, Dr. Bila. So what I've seen also over the years is when the doctor comes in, mostly, I must say this because I'm a professional nurse. So mostly it would mean that maybe when the doctor comes into the ward, there isn't a sister available at that particular time. Right. So usually the doctors are in a hurry most of the times. So because they know they go straight to the patient, they speak to the patient, and it could happen that a lot of things that maybe the doctor would have told the patient was missed by the sister, while the sister was maybe being called in another room and having to go and get the trolley, the doctor's trolley, to follow the doctor where the doctor is. By the time the nurse gets there, the doctor has already started speaking to the patient, and the nurse comes in and joins into the conversation the doctor has already started. So there, you, as a nurse, I would have missed a lot of maybe important things that was said while I wasn't there. And then also you would find out that sometimes when you get there, the patient would tell you that, no, the doctor came and this is what the doctor said. So what normally would happen is, as professionals, professional nurses, we would write on the doctor's round book that doctor came in at this particular time and this was the orders. So now these orders, we would then hand them over to one another. So now what would happen then could be that maybe if there's anything that was missed between the doctor and the patient and the nurse during the time when the nurse was coming, that becomes forgotten or rather omitted, and the doctor would actually maybe assume or expect that order to be carried out. And because it's missed, then tomorrow morning, because you cannot really determine when a litigation is going to actually follow you. So should a litigation perhaps maybe spike, the doctor could actually come through and say, but I said this. And the nurse, I would say, because I'm a nurse, has every right to say, but I did not hear you. And the patient would say, but no, the doctor did say, but maybe I was not there. I was getting the trolley and I was pushing the trolley to see the doctor and the patient. And I came in while the conversation was already happening. So I would rather ask if the doctors could actually work hand in hand with the professional nurses, give us time, because mostly you would always find a professional nurse running or being the shift leader in the unit and maybe working with an EN and maybe an ENA as well. So already you can see that there is maybe short staffing happening there, and they mustn't assume that the system maybe doesn't want to do the rounds with them. They mustn't assume that, but it would be very nice that when the doctor comes to give maybe a few minutes to find out where's the sister, and also wait for the sister and go with the sister to the patient, not for the sister to go to the doctor and find the doctor already having the conversation with the patient, because obviously I would miss a lot of things.
Thank you very much. Yeah, so it does, you emphasize the fact that when the doctor goes to do a ward round, the nurse should accompany the doctor.
Yes.
And together they need to document what has been discussed between themselves and with the patient. Lebohang Dlamini says, we forget once that one's record is the best form of communication that will represent you when you're not present and the writing is not clear. And if the writing is not clear, it creates a gap that can lead to a lot of problems that can be explored by the family and people like Mr. Nyatela here. Mr. Nyatela, any comments? Mr. Nesisa, you too also? I mean, I think what you say that clear handwriting, it should be legible.
I do, Doctor. I do.
Yeah, go ahead. Yeah. Go ahead, Mr. Nyatela.
I do. And, my comment is as follows. We have a lot of cases where medical records are unavailable. You see that a lot in public hospitals where the litigation is against a certain government department, for instance. In those such cases, you find that there's difficulty in proving a claim because the records are simply unavailable or insufficient or illegible. And we can't quite make out what the doctor or what the healthcare practitioner was trying to say. That does not work in the health practitioner's favor, because then no one is able to, it remains to the health practitioner to try and persuade another expert or the court that what they were trying to say is what they were supposed to say. And my point there is that health records must be kept, but they must also be legible and they must be kept in a proper condition. This is particularly important because we all know that medical legal disputes do not arise on the day that the incident occurs. They usually arise a year or two or many years later after the healthcare practitioner has completely forgotten what was happening. People today will be able to speak for you on a day that you cannot speak for yourself. And for this reason that we encourage proper, legible medical record keeping in both public and private hospitals.
No, thank you. Thanks for that comment, Mr. Nyatel. There's a question from Narendish Ramdani. How long does a retired GP need to keep patient records? I suppose it's not only a retired GP, it's everyone else. How long should you keep patient records? I suppose this is when you say retired GP, someone who's closed the practice, or when it's someone who may not have handed over the practice to another practitioner. So how long? I think number one, the GP, retired GP should keep records, and in general. If you want to comment, Mr. Nesisa or Mr. Nyatel.
Okay, I can try and comment on this one. So for me, honestly, because these litigations come even years, 20 years later, I would rather suggest that you can keep it maybe for as good as maybe that 20 years or so. So you can always go lock it up somewhere else. You don't have to keep it in your space in your house, but you can always look for a place where you can lock it up and keep the key just in case, because you never know.
That's a great reply, Nesisa. And just to add on to what you're saying, much as it is the safest to keep them for the longest, we also need to know the benchmark. What is the shortest period of time by law that you can keep the health records for? And, to arrive at that answer, we're guided by the Health Professional Councils of South Africa's guidelines on the keeping of patient records, also known as Booklet 9 of 2016, which provides that the health records should be stored for no less than 6 years from the date that they became dormant. That is from the date that the doctor had a last contact with the patient. So to expand on that a little bit, Dr. Bila, I wouldn't rely on the date that the practitioner went on retirement. I would rely on the date that the practitioner last made contact with that patient, because that is the date from which the 6-year period starts to, we start to count it from. And so suppose he retires in 2025, but he last made contact with the patient in 2023. He would be required from 2023 to keep the records for the 3-year period that he's still in practice, and even for another 3 years after he's gone on retirement. And that's just by law. Beyond that, and like Nesisa is saying, to be safer, you would want to keep the records for as long as possible, especially in the obstetrician, gynecology, and childbearing space, where we see a lot of litigation for children who are born with cerebral palsy and adult. You still find attorneys bringing litigation in those matters. So you want to be able to sleep peacefully at night, knowing that your records are properly stored, and they're stored for as long a period of time as any anticipated or potential litigation.
Thank you very much, Mr. Nyatela. Yeah, I think it will be important for all practitioners to familiarize themselves with that booklet 9 of the HPCSA, and I think even the Nursing Council also does provide guidance on how long. Cody has just mentioned also that mental patients, lifelong, minimum 20 years, and I think the same applies for children. That you need to keep them, especially if they keep them up to the adult age, and then also for a longer period. You can't destroy records of a child, because you never know what's going to happen when they reach age 20, because then they're legal adults at that time, then they can also raise issues on their behalf. Someone who says it would be nice to get a paperless record system, because it would help both patients and the medical personnel. I think we're in that era already, where most groups, even in the public sector, everybody's being paperless. And I think there are guidelines also as to how to keep. But yeah, you need to make sure that everything that is required, it is also kept. You need to choose the best system, IT system, that can help you to record everything that needs to be recorded. There's Mzamo Chakavula says, let's say you've raised issues in your unit with your managers, like short staff or absence or faulty critical equipment, and they do nothing. You've documented the communication, then an adverse event occurs to a patient because of one of the factors while you are on duty. It is found that one of those factors you reported hugely contributed significantly to the event. Who bears liability in that instance? I don't know if you want to take a chance on that, to Mr. Nyatela.
This is a very tricky one because as the professionals, we are trained to actually do the right things, right? So I commend the professional for actually doing the incident report and actually putting the record straight, because then now that's the correct thing to do. So it would mean that then the manager would, for me, then the person or the manager or the person in charge should be the one actually liable or to actually take the fault, because they're not doing anything about it even after an incident has been written, because the colleague that has actually raised the concern, the colleague that has actually written the incident or completed the incident or maybe entered on him, so wherever, has proof that this is what I've done, I have reported. So now the person that actually has to action out the complaint hasn't done anything. So for me, I think it would be the person that hasn't done anything, meaning the supervisor or the manager that hasn't acted on that, to actually allow or open up for a gap of an incident like that, where now the patient actually gets to be harmed because of that.
Well, I think true, Nesisa. Okay, go ahead, Mr. Nyatela, go ahead.
Doctor?
I'll say go ahead. You wanted to respond to this question, yeah.
Oh, yes, I think it's purely an issue of collegiality. It's purely an issue of covering one's tracks. It's purely an issue of maintaining a record of lapses in leadership and management. Now, what do I mean by that? By that, I mean that we have say, you have harmed me while I was to prepare a defense for the hospital, only to find that there is nothing that we can say in the hospital's defense because the records aren't there. And if somebody holds back on noting down this kind of information and the records aren't there, they cannot easily come later and say it was his fault or her fault. Why? Because they didn't note it down. So I would say between a decision to note it down and a decision to note it down, even though it's going to affect your relations with that particular manager in the future.
So thanks for that comment, Mr. Nyatela. Also, Lewan says that the rule of thumb in management of patient safety incidents is that clinicians shouldn't be blamed or shoulder the responsibility of a faulty system. Yeah, I think that summarizes it. The next question, I just want to make a comment that Sister Nesisa Ngwenya here is doing this presentation in her personal capacity. So she's not speaking on behalf of clinics, neither am I speaking on behalf of clinics when I facilitate this webinars. I'm here to facilitate and get opinions. It's an engagement, an academic engagement with various speakers, people who've got experience in clinical care, whether in the public or the private sector, done research work. And so I think that's how we should be doing. So we will not be able to answer this question, the direct question, like what is clinics doing in terms of using things like spoken AI. It's a policy matter that each health group or each business will have to make a decision about, and I'm not in a position to comment on that. But we know that AI is something that we need to be embracing in in our clinical settings everywhere, and it's something that one should consider. It's something that is here with us, and we may have a conversation and a discussion later on about the importance and value of AI in clinical care. We've done the same. I think there's a time last year we spent the whole month discussing AI and machine technology. Next question is, or it's a comment. I think it is essential as a multidisciplinary team of professionals to be all on board, especially in theater setting. Often consents are missed, leading to malpractice because of lack of communication, e.g. surgical pause not being initiated. We need to collaborate. Although we aim to be time efficient, we need to ensure that we render quality health service. Therefore, patient needs to be managed in totality. I mean, as a theater nurse, the surgical pause is quite important. As she says that we don't need to be in a rush. Take that moment. That surgical pause is important. That will save a life. Your comments? Mr. Nesisa?
Yes, Doc.
Yeah. What about surgical pause? I mean, it's a comment. I don't know if you want to add anything to that.
Yes, I would like to add something on that. It is very important as a theatre nurse myself as well. So mainly, or most of the times, we always pushing on like being so fast to try and have a quick turnover, but at the same time, we need to actually do the surgical pause. I think most of the times, I'm not sure whether with some of the medical practitioners, perhaps maybe they don't understand how surgical pause is supposed to be done. I think maybe if we could actually assist each other, like you've mentioned, that this is a discussion which is assisting each other and helping each other as a team of professionals from all over healthcare facilities. So for me, surgical pause would actually be best done when the patient comes in to theatre, and actually would have the surgeon coming into theatre together with the anesthetic doctor, with the anesthetic nurse, with the scrub nurse, and the circulating nurse. So everybody's supposed to be in the team with the patient before the patient is actually put to sleep, so that the patient can actually verbally consent to whatever that the procedure is going to be done on them, and everybody can listen so we do not miss anything else. And then it gets repeated again before the surgeon could actually put the knife to skin. For me, that becomes the best surgical pause that can be done versus having the surgeon not in theatre and you having an anesthetic doctor that pushes the patient in theatre and the surgeon is not there, and surgeon only rocks up when the patient is already sleeping. I think as medical professionals, we need to look out for such incidences, because it is an incident. It's how do I put it? It's a near miss, basically, because then now, what if maybe there's something that we're going to omit and ends up causing or leading to a litigation? So we need to help each other as medical professionals and remind each other that we need to do things the right way as a team, as a theatre team.
Thanks for that. Yeah, we've got lots of questions. Initially, there were not many questions, but it's quite an engaging discussion now. I think there was a question that I saw. Is it legally correct to document information if we write on the progress notes later as a late entry, excluding medication or, for example, the next morning? Late entry, what's the position?
For me personally, remember, what's not documented is not done. So there is room for late entry. So because most of the times you might find out that people are busy and they miss out to put other entries, but then now the challenge then becomes the inconsistencies, because I think in one of my slides, it's spoke of inconsistencies of entries in the file, whereupon today's the 18th, and if I was nursing a patient in a medical ward and I'm at home now and I've forgotten to enter something, then tomorrow is the 19th. So I am going to continue perhaps maybe on a new cardiacs, and someone has already started the 19th and I come with my late entry. So I'm not sure. I would ask Mr. Nyatela to just come in on this one. But for me, I would say late entries, definitely there is room for late entries, because if you do not end up writing, it could actually lead you to a fault should a litigation arise. So it's better that you actually enter it than not enter it at all. Mr. Nyatela, what's your take on this one?
Yo, Sister Nesisa, this is quite a risky one. I have
Mm-hmm.
had a matter where a child was deprived of breast milk. And in this instance, the child developed some conditions, some sequelae as a result of being deprived of breast milk and tinned milk. But what's notable in this case is that the medical practitioner, let me say, who was writing the records, seemed to indicate that the child is fine. And that was what it looked like on their records during their shift. But later on, the person who took over the shift from them made notes that to the effect that this child is not fine and this child has not been fine since this child was born. And so it became difficult to defend the initial medical practitioner's notes in the face of the notes that came after that seemed to suggest that the child had not been okay the entire time. So that's the problem. The problem is now once someone else comes to say that your notes are inconsistent with the truth, you cannot come later while they've then, well, I'm coming here to add on my note to indicate that the child is in fact not okay. Another classic example is with cerebral palsy incidences, where you've got children who are born with cerebral palsy, but the APGAR scores seem to indicate that the child is fine. What the court's attitude is towards that is that this is gross dishonesty. And not only is it gross dishonesty, its attitude is that this dishonest conduct was done deliberately to conceal the real condition of the child so as to avert liability on the part of the department. And so it becomes difficult to defend that kind of situation where the APGAR scores are noted as, being okay. And later on, when somebody else other than you, someone more objective, picks up that the child's not okay, you can't now then, as the person who's written down notes in the APGAR scores, come back and say, well, I made a mistake, or, I made an omission and I actually want to correct it now. However, I just want to add the caveat that sometimes this does happen in practice, where you realize after the fact that, you forgot to make a note, which you should have made. And now that you want to make it, it's just going to look awkward in the records. Should you make the note or should you not make the note in a practical sense? Do make the note, but I would say do make the note, but it's a risky note to make. For someone who wants to defend themselves later, you're safer having the note and explaining to the court that I made this note ex post facto because I remembered when I got home that I hadn't made the note I was supposed to make, as opposed to not making the note at all and realizing that you hadn't made the note that you should have noted and keep quiet about it.
Yeah, I think maybe what I've also heard is that when you make that note, don't write the date when you should have made the note. Write the date when you are making the note, so that it is clear that it's a post facto matter.
Dr. Bila?
Okay.
Yes.
Correct.
Sorry?
Can I just add something?
Okay, go ahead.
Yes, I just want to share that during my training as a nurse, we were taught that when you're making an entry in the patient's record, you need to make a note as though, or imagine yourself standing in a court of law, that will you be able to defend yourself on whatever that you're writing. So with that mindset, over the years working as a professional nurse, it has assisted me in so many times, because when I write, I imagine myself standing at the court of law and being asked questions. So then it kind of helps me to actually write in a way maybe legible, in clear form, and notes that are actually making sense. So I'm not sure if maybe that could actually help the other professionals as well, that with every entry that you make, just think of yourself standing at the court of law. Perhaps maybe that would assist, so that maybe it might omit a lot of things that we actually tend to omit and cause a gap for litigation. Thank you.
Yeah, no, that's quite good. I think I had one professor many years ago and they describe this as defensive medicine. You know, you write with the mind that you may be challenged about what you've written and you have to defend yourself, but you do the right thing at that time. Thank you. There's a direct message sent to me, and this person says, in the institution I'm working in, we have a problem of missing files, especially the MVA files. And most of the time when they come for their reviews in the physio department, they come with duplicate files with no information inside. Then what do we do in such instances when the information is lost? Especially when you look at what is not done, what is not written is not done.
Mr. Nyatela, would you like to take this one?
I'm sure
You know
must
what?
have come across such things.
Yeah.
We do. Sadly, this happens with medical negligence cases as well. The rate at which hospital records are being stolen is alarming. You know, it would appear to me that attorneys are working with people who are in the records departments to get them the medical records, to steal those medical records on their behalf so that they can gain a competitive advantage against their, colleagues in the medical legal space. This is especially true in medical malpractice cases, more than it is for MVA. It's far more prevalent in medical malpractice cases precisely because the attorneys, these unscrupulous attorneys, are trying to get the department in a position where the department will be unable to defend itself. So what's the best way to get the department to be unable to defend itself? Well, take away their potential defense, which is their medical records. So medical records are in fact for sale. There are people, touters, who work for certain law firms who go around in these hospitals interviewing MVA claimants and medical negligence claimants and colluding with the records department and personnel at the records department to steal those records on their behalf for a fee. And sadly, this is something that's already happening, and it's happening at an alarming rate. And I would say for a hospital, you are in a better position preventing this than trying to cure it. You're in a better position, for instance, using cloud-based software to manage your records, as opposed to a paper-based approach.
Yeah, you've just commented on the other question. What's the legality of saving documents on platforms like the cloud with the risk of being hacked and compromised confidentiality? You just in your last statement now, we seem to allude to the fact that cloud is much safer. Maybe if you comment on that.
It is. When we did the legal audit for the Gauteng Department of Health, we found that one of their greatest weaknesses is their inability to keep records. And their inability to keep and manage records means that they are unable to defend themselves, even if a potential defense exists. Now, attorneys have taken advantage of that. Attorneys and other people, IT technicians, will still continue to try and take advantage of a cloud-based system, but the prevalence of that is quite low in this day and age. But unfortunately, the risk is quite high. Attorney and I have got a medical negligence case that I have against Gauteng Department of Health. And I want to gain a competitive advantage against my opponents, which is Gauteng Department of Health. I would probably get a touter to collude with one of the personnel in the records keeping department to steal that particular file. Now, the risk that the department faces is the loss of that particular file. But if I am a firm of attorneys and I've discovered that a private hospital group is using a cloud-based software, and that cloud-based software is vulnerable to hacking, and all the patient records are kept under that one particular cloud-based software, then the risk is much greater that if that hacker is able to break in, he's able to gain access to far more many files than in a situation where it's paper-based. So because the terrains are different, the risks are completely different. But I wouldn't say that the departments or the hospitals should remain in a paper-based way of doing things simply because they are afraid of the risk of getting hacked. Unfortunately, that risk you cannot prevent. You can only mitigate by getting good, reputable security to manage your systems. Okay. Now, I see there's a question in the chat. There's a question in the chat that says, is it legally, excuse me, what is the legality of saving documents on platforms such as cloud with the risk of being hacked and compromised confidentiality? Unfortunately, we do have, as a medical profession, the duty to maintain records in a manner that protects the confidentiality of those records. And unfortunately, in migrating to a cloud-based system, the risks that I've alluded to earlier on exist, and those risks speak directly to patient confidentiality. And so it has to be a value judgment where you look at the risks associated with a paper-based system and compare them with the risks associated with a cloud-based or software-based system. And I would say that most hospital groups, most private hospital groups, and more recently, even the various provincial departments of health are beginning to see far more benefits in a cloud-based system, although it's risky, compared to a paper-based system.
Yeah, I think the times are changing, and that most healthcare groups are going towards a paperless system and actually a cloud-based system. As you say, you need to have proper controls and tight and be aware of cyber crime. And so anyone has to invest in cyber security.
Doc, can I just add?
Yeah. Sure, go ahead. This is the last
comment. Can I just add, Doc, to amplify my point about the risk that exists that the patient's records may be accessed or intercepted, thereby breaching the client-customer confidentiality rules. I would say, under those circumstances, a prudent hospital group would include in its patient admission forms something like a clause that they do have in writing and do also explain to the patient that we have migrated from a paper-based system to a cloud-based system where risks exist that our system could be hacked and confidentiality may be breached. Under those circumstances, the hospital accepts no liability for a breach of confidentiality posed by hackers or information thieves. In that way, then the hospital group and its personnel is protected from that risk in the event that a patient wants to sue from or arising from a breach of confidentiality as a result of the.
Thank you for that comment. I think it's the risk that it's not only faced in the private sector, but also in the public sector, because I know that with NHI, that's where we will be going with this paperless system, because there'll be one health system with one electronic health records for the whole country. I just want to take this opportunity to request Professor Sipati Makunyan, who's our one of the members of the risk committee, and I think she's also passionate about ethics, just to make a closing remarks. Prof. Makunyan.
Thank you very much, Dr. Bila. Yeah, on behalf of Clinics Risk Committee, I extend our heartfelt gratitude to our speakers tonight, Mr. Nyathela and Sister Ngwenya, for addressing this. This is a very pivotal and extremely important topic in medical practice. And we really appreciate your insights on medical malpractice, especially with a keen focus on this meticulous documentation of records, record keeping, and effective communication among healthcare workers and their patients. We also would like to extend our sincere appreciation to the organizers of these weekly webinars, as well as to each participant for their engagement on a weekly basis and commitment to enhancing patient care and safety. And to Mr. Nyathela, the statement you've just made right at the end of your, as your last comment, I really hope that we will get it in writing somehow, because I'm sure we can use it even as individual medical practitioners. On that note, I would like to hand over to you, back to you, Dr. Bila. Thank you very much.
Thank you very much, Prof. Ngwenya, and thanks, colleagues. Thanks, Nesisa and Mr. Nyathela for joining us, and all the colleagues and the team from marketing, Kamo, Anza, and Sistoko. And we hope to engage with you again next week with the next presentation, and have a good evening.
Thank you.